So one of the things that I think Bill introduced to you is that it's important that we get rid of the leukemic cells, but you have to think in terms of the leukemic cells are in a person, and the person is more important than just the leukemic cells, and we have to figure out different ways that we can keep on enhancing our ability to have people not only be free of leukemia for a long time, but be normal while they're free. And this used not to be a problem, because our biggest problem used to be about 25 years ago, just getting rid of the leukemic cells. We couldn't do it very effectively, but we're a little bit better at that now. So I'd like to introduce myself. I'm Michael. I've been accused of being a legend in my own mind, and that's probably true. But the good thing is that I'm going to keep the transplant situation fairly simple. And it's difficult, as Bill said, to get your hands around the immune system, but it's also difficult to get your arms around transplant, because there are all these terms which doctors like to throw around, and sometimes we don't mean to confuse you, but sometimes we do mean to confuse you because we don't really know the answers ourselves. So a stem cell is a cell which, when it divides, is able to make a copy of itself so that you never run out. And the other cell keeps on going along to make daughter cells and make the future. But a couple of people have demonstrated, including Dr. Esrov, who works with us, that you can put a few genes into any cell and turn it into something very similar to a stem cell. Autologous is a term that means that we get these stem cells from our own body. We're not importing them from some other person. If we do import it from another person, it ends up being an allogeneic cell, so an other gene population. And we used to have all the time, we would do autologous, and that was not very satisfactory. Allogeneic was a higher risk situation, but long-term benefit. But not everyone had a family member that was a match. So that as the technology got better, we were able to find out that we could find matches for a lot of people out there in the community if we had a big enough donor pool to search from. So this is blood that's left over after birth in the placenta and in the umbilical cord. There are two ways of doing it. You can go to a private service and they'll charge you an arm and a leg, and even if it's from a family member, it's unlikely to be useful for you anyway because it's only a partial match, or it's better just to go to the public area and donate the cells that way. When I first came to the MD Anderson, we were first doing transplants in the mid-1970s, the upper age limit was around about 40. Because it was so dangerous to go through the transplant procedure. And the main problem was that if you did the full transplant, you would have to deplete the patient's own bone marrow to do the bone marrow or stem cell transplant. And it was sort of like a scorched earth approach. You did a lot of damage, and then you hoped that the cells that you put in would grow. But fortunately, as we developed fludarabine, a drug that Bill Plunkett had a major role in, we found out that we could suppress the immune system enough that we didn't have to wipe everything out, and then we could come in and give stem cells from other people, and they would engraft, they would take, they would grow, and they would develop a process where they killed off the leukemic cells. So it's basically, we've found out that in CLL transplants, the major benefit that occurs actually occurs not because we're wiping the cells out to start with, but the new immune system that goes in. These immune cells are what kills them. So we have autologous transplant, and they've been done very extensively, particularly over in Europe, and it gives them a somewhat prolonged remission, but everyone relapses. The good thing about allogeneic cells is that if you get through the transplant procedure without having some really serious effect, half of these patients end up being cured of the disease. So it's a short-term risk, a long-term benefit. So that we have to balance out the risk. So you identify patients that have an abnormality in chromosome 17, which are at highest risk. but it can be managed, as some people in this room will be able to attest to. If you don't do very well on either your first treatment or your second treatment, there's some resistance factor there that suggests that you're not going to do terribly well whatever we do for you. And these patients will often do very well with a stem cell transplant. And so if you relapse quickly, you haven't had a long remission, we should be advising you to at least consider a transplant. And if you have a transformation that was described by Dr. Richter into a large cell aggressive lymphoma, that's a difficult situation for us to handle. So as I mentioned, if you do an allogeneic stem cell transplant, either from a sibling or an unrelated donor, or if you have matched cord blood, about half of these patients will end up being long-term survivors. And I think a gentleman came to see us the other day who had his stem cell transplant 15 years ago, and it was really difficult to recognize him and he me, because I used to have colored hair and I used to be slender and athletic and all those things. And he said, "Are you really the same guy?" And I said, "Yes, I am." "Are you really?" And I said, "No, you're not really, because you got a transplant from your sister, so you're really half a woman now." So the unrelated donor situation is balanced out because it's more effective in killing the leukemic cells, but there's somewhat more of a risk of the cells attacking the person that receives them. So that there are some uncommon things where you have acute graft versus host disease, where the patients develop skin rash, diarrhea, and some other complications. Sometimes the graft is rejected, you haven't suppressed the immune system, that's not common. And dying in a year after transplant from infections is also now uncommon because we're getting much better at protecting them. It's a lot more common to have a lingering pattern where there's predominantly skin manifestations, but even so, about 90% of the patients can get off any suppression of the immune system within a year to 18 months. So one of the things that's important is that patients often want to go home to have their transplant if they're not from Houston. And one of the things is that there's about a 10% differential in whether you're cured or not. Because a lot of transplants are done by centers that don't see a lot of CLL, so they try and fit the transplant that they're using for myeloid leukemia or solid cancers, etc. in. And as I'll mention in a little while, one size doesn't fit all. So we're getting much better at matching. It used to be 4 out of 4 match, and then 6 out of 6, and then 10 out of 10, and we've been able to find that if there's a single mismatch, some of them are important and some of them aren't terribly important. It's better if the patients are done earlier in the course of the disease, but the downside of that is that they've got a lot of time that they're going to have in fairly good health, and they don't want to take the risk. So balancing the risk and benefit is something that really needs to be individualized between the patient and the doctor. So one of the things is that this drug lenalidomide that Bill Weirder alluded to, that improves the immune function, is actually much better at allowing the transplanted immune cells to recognize the CLL cells and kill them off. And this is something which I think is going to be very productive in us figuring out how to improve the margin from the patient's point of view. The education of patients' own cells. Well, one of the things is that if you have a CLL cell sitting next to an immune cell, they don't talk to each other. So one of the things that Bill Weirder has done, together with Tom Kipps, is done some gene therapy, which is very effective, but unfortunately it's difficult to get access to it because of corporate issues. But it can switch on the CLL cells so that the cells become a cell vaccine. We can also, as Bill mentioned, expand up the T cells or the immune cells, and also now the natural killer cells. And if you incubate them, they recognize each other. If you throw lenalidomide in the mix in about 5 to 10 minutes, there's very active recognition, so that we're beginning to figure out how to make the killer cells much more acceptable at killing off the targets. And some of the targets on CLL are very specific. There's a B cell receptor on the surface, which is unique to every patient, so that you don't have to worry about affecting the other cells in the body because you're only attacking the B lymphocytes. And there are two other proteins, one called ROR1 and one called TOZO, which are potentially very interesting targets. So what we need in transplant is for the doctor, the CLL physician, to be able to start talking to the patients realistically about what they can expect. As I mentioned, don't go to a place where one size fits all, that they're just going to fit you in to the transplant technique du jour. It's not a good strategy. There are about 3 or 4 places around the US that I'd recommend, and that would be all. Fortunately, one of them's here. We need to see if we can guide the patient through their fears, because they're very realistic fears. And we need to support them if they have a denial from their insurance carriers. And the way that we will lead to the cure of the disease using these technologies is just to do continuous research.